Thank you guys for sticking around. Actually, I'm going to do a comparison study where we looked at quadricep strength with a medial pivot total knee and a posterior stabilized total knee. I want to thank my partner, Mike Christie, for contributing the posterior stabilized knees. So these are my disclosures. So as far as background, and I was a little nervous about giving this talk because the guy that I got the idea from sitting right next to me, and I didn't want to misquote him, but in 2014, we had a meeting like this here in Chicago, and Dr. LaMontagne presented some data on patients going from a sit to a stand, looking at EMG data, comparing a PS to a medial pivot knee. And in that session, he showed that a greater hamstring amplitude on the EMG in the PS knees compared to the medial pivot knees. And he also showed that there were demonstrated greater quadriceps amplitude in the PS knees than the medial pivot knees, meaning that the medial pivot knee was more efficient. And so he subsequently, let's see, is it? There we go. Presented similar data on muscle activity while ascending and descending a ramp, and presented this, I believe, in London, England, and it hit the orthopedic proceedings. But basically, something similar. He showed that during the ramp-up test, the TKA group, so he was comparing medial pivot and PS knees to normals and then to themselves. He said the TKA groups compensated the tibial anterior translation by activating their hamstrings more and for a longer duration. But the medial pivot group required less hamstring activation than the PS group. So the way I took that was that when someone was going from a sit to a stand, if you were in the PS group, you have to create a fulcrum which you pivot on. So you fire your hamstrings, the hamstrings pull the tibial post into the femoral box, and then the quadricep fires to stand up. In the medial pivot group with the ball and socket, we didn't have to have as great a hamstring activity to stabilize the pivot point, so you were able to easily fire your quads to stand up, and that's why the quad amplitude was less in the medial pivot group. So with that, in our office, our therapists use this handheld dynamometer, and here it is, and here's a picture of, it's not our office, but just a picture I got off the web, but demonstrating how you would use the handheld dynamometer. And so I thought, well, let's try that, and then I started thinking, well, I don't even know if this handheld dynamometer is good. So I did look up a couple of studies. These are from kind of the physical therapy literature. But there was a couple of really good studies that were pertinent to what we wanted to do. One study compared the handheld dynamometer to the gold standard, the Cybex isokinetic dynamometer. And they showed that there was excellent intra-tester reliability, and it can be used to compare strengths of different subjects or one subject at different times if it's used by the same assessor. So that's what we did. It's a second study that I thought was really pertinent because it was looking in geriatric patients aged 61 to 80, and it had 20 patients in that study, and they also said that the handheld dynamometer offered a feasible, inexpensive, and portable test of quadricep strength to use in healthy older patients. So we then created our hypothesis that the increased sagittal stability of the medial pivot knee would result in a faster return of quadricep muscle strength compared to the less sagittally stabilized posterior stabilized knee in total knee arthroplasty. And then we thought also that the greater hamstring force required to stabilize the PS knee would lead to a lower quad efficiency than the medial pivot knee during sit to stand. So we had 2 patient cohorts. There were 50 patients in each cohort. All were inpatient surgeries. All were anterior approach with mid-quad arthrotomies. All were unilateral primary knees with no other joint procedures. Our ages were the same, BMIs almost identical, length of stay the same. Discharge locations, the medial pivot, 4 of them went to either a SNF or an inpatient rehab. Posterior stabilized went to the patients went to a skilled nursing facility, and all others went home with outpatient physical therapy. So we tested at pre-op, 6 weeks, post-op, 6 months, and 1 year. The first thing we asked them to do was a sit to stand in 30 seconds, count the number. We used the handheld dynamometer, and our therapist, you have the patient give you one kind of pre-maximal load, and then you have 3 trials. If all 3 are the same or similar, you use all 3. If one's significantly different, then we would throw one out. We did it at 15 degrees of flexion, 45, and 90. So here's our sit to stand data. The medial pivot is there on your left, the PS on the right, and the intervals are right here, pre-op, 6 weeks, 6 months. So you can look at the start, the medial pivot and PS group were not statistically significant, but at 6 weeks, 6 months, and 1 year, the medial pivot group was statistically better at sit to stand. If I can get this thing to go forward. And this is the same, this is the graph of that. So the pre-op is far left, and then you can see that the slope was about the same, but the magnitude, the number of sit-to-stands was greater. And if you compare each subject to themselves, so their percent increase, you can see a significant increase between pre-op and 6 weeks, a little more at 6 months and a year, but definitely in the first 6 weeks made a huge difference. So we looked at quad strength, and it's a little data heavy, I'm sorry, but if we looked at medial pivot and we were just measuring quad strength at 15 degrees, if you look at the numbers, comparing pre-op all the way to 1 year, we were only statistically significant at 1 year in terms of the 15 degrees. And here's kind of the look of that graph. Again, these are averages for the total 50 patients in each group. At 45 degrees, again, almost identical. Took a year before they were statistically significant. But in general, the PS group, or the medial pivot group was stronger in all categories. And then the last was at 90 degrees. 90 degrees, we saw an interesting phenomenon where we actually lost strength at 6 weeks, but at 6 months, we were statistically significantly stronger in the medial pivot group compared to the PS group. And we were stronger, but didn't make the P of 0.05 level at 1 year. And here's that graph. So the medial pivot knee was statistically better at 6 weeks, 6 months, and a year in sit to stand compared to the posterior stabilized knee. And I think sagittally stabilized knee design seems to provide a faster return of quadricep strength after total knee arthroplasty. Thank you.